All right, so let's get started. So, what must be done now and what can safely wait? So, my disclosures, I hope, are in the final program. Like I said, we mix things up. I don't want to go through details. Unfortunately, for some very legitimate reasons, uh, we have two changes to our panelists this morning. So, like I said, we have Dr. David Galos, who's here with me at Temple. We have Will Ryan from Rothman Institute. We have Dr. Spence Reid from Penn State Hershey, and we have Dr. Hassan Mir on the call. Dr. Mir, can you hear us okay? I want to make sure I can hear you.
Yes, I can.
Great. You guys can hear that okay in the back. Perfect. Excellent. Always good to get off to a good start with the audio visual. All right. So one way to think about it, there's kind of like two clocks running. On the one hand, we pay a lot of attention to antibiotic timing, like an open fracture comes in, how quickly are they getting antibiotics? And then we also think about, when does a patient need to go to the operating room for debridement? And I think those are the two things that we'll be talking about today. So for those of you who've been practicing for a while, you know that there's a 6-hour rule, and many of us know that it doesn't really have the best data to support it. This is a systematic review paper that's a nice one to take a look at if you get a chance, by Dr. Schenker, probably when she was a resident, that kind of definitively helped to look at this and say that probably doesn't have the best support, but certainly doesn't suggest that you should just delay everybody. So it doesn't mean you need to electively delay everyone, but you can't really say that there's a good 6-hour rule supported by evidence. I think that within 24 hours, for the most part, is kind of the default for many cases. And so I don't want to say that's a rule either. And, here are some prospective evaluations, some guideline papers, some other references you can take a look at. The one on the left was a prospective observational study, and didn't really show huge differences when you look at that. And a lot of studies, we're involved in some clinical trials with open fractures, and generally, to not be an outlier, you'd have to get debridement within 24 hours. So for many intents and purposes, that's more or less what you hear nowadays. So what about antibiotics? It's definitely a quality metric. That is, if you're at a trauma center. So we are here in Pennsylvania. So the Pennsylvania Trauma System Foundation does look at this. And that for that reason, I can tell you here, you get some support for it. As a matter of fact, trauma team and the emergency room even came up to me and said, "Hey, we noticed that we're lagging in our antibiotic timing. Well, they initiated a quality improvement project, and we were able to include that." There are many things you can do. Type of antibiotics you use. If you use gentamicin, it's weight-based. It creates huge delays. But there's definitely some evidence that you should get antibiotics within an hour. Although there's now some evidence that suggests maybe that's not even we shouldn't be as dogmatic about that as maybe we thought we needed to be. So that's gotten a little bit muddy. So certainly, if you have an open type 3 open tibia fracture, you would think that antibiotics timing is really important. So this is the paper I was referring to from Shock Trauma that, at least in this series, retrospectively showed that maybe timing of antibiotics was not as critically important within an hour. So just food for thought. It doesn't mean that we shouldn't give antibiotics in a timely manner or within an hour or shoot for that, but you should just know what the data says nowadays. So with that little bit of background, this meeting is fairly case-based, so we try not to go straight through with lectures. So, but I do think it's helpful to get a little bit of background. We'll try to come back to some of those points in the literature and try to make some take-home points. So this is my first case. So this is 8 p.m. motorcycle crash, type 2 open tibia. Looks something like that. Doesn't look grossly contaminated. Patient gets ansept, reduced splinted. Okay, so here's like your prototypical fracture. So this is kind of what I'm asking the panel. Is this, and this is kind of what we're going to go through in this session. Is this something you're going to take now in the in the middle of the night? It's 8 p.m., but by the time you get this person in the OR, it's going to be much later. Is this a first case in the morning? And is that something you can do at your center where you can just make it happen? Or is this happening in some kind of trauma block the next day? Dr. Mir, thoughts?
Yeah, so thanks for having me, Saqib. So, couple comments. I think, firstly, you mentioned no gross contamination. The stuff you mentioned, no vascular injury, no compartment syndrome. So this is not something that I would be doing in the middle of the night. I think that a couple other things. One is that I tend, and our center has written on this, we tend to not try to classify the grade of open fracture in the ER because by definition, you're kind of supposed to do that in the OR, right? And determined by how much periosteal stripping there is, how if there's myonecrosis present. So we treat everything in the ER as if it's a type 3 open, and base our antibiotics off of that, and then we'll tailor it back once we get to the OR. The other thing that we do acutely in the ER is
By the way, I'm sorry, for those in the audience who didn't look at the program, Dr. Mir is at Tampa General in Florida. Sorry to interrupt you.
yeah, no worries, no worries.
So that's where you're
Yeah.
talking about.
Yeah, but that way they know who this guy is who's rambling. So secondly, there's something that we've published a single center series and a multi-center series on now, and you may cover this later, but applying local antibiotic powder. There's been bigger publications, prospective multi-center RCTs on antibiotic powder at the time of definitive fixation, and that's pretty common in a lot of different subspecialties now. But we started applying powder in the emergency department basically on any wound that is big enough that you can put powder in. And we have actually lowered our infection rate for open fractures by doing that. So in addition to your sterile saline soap gauze, we would sprinkle it with antibiotic powder before putting that on. And we actually have data from multi-center studies now to indicate that that helps.
Interesting. By the way, you may not remember this. You're the first person who told me about antibiotic Venco powder back in 2012. We were in San Diego having lunch. I distinctly remember you telling me this, and I was like, what are you talking about? And you talking about how they're doing it in spine, and now you're doing it. And that's the first time I kind of found out about, by the way. All right, very interesting. Well, that's why we kind of get different people together from different centers, and I didn't want to drag you all the way up here, but most of our other speakers are a little bit more regional here. So I would, just quite simply, I'll just ask the panel, would anybody disagree with that? Or are you pretty much okay? Are we in agreement, or would you do something different? In terms of timing, let's just say, not other nuances Dr. Mir talked about.
No big disagreement, but I think, you have to ask yourself, the big spectrum is at one end, what you can defend in court, at the other end, what would you want for your own family member or you? That's sort of like where we're working on this spectrum, I think, practically. We never gave type 3 antibiotics necessarily in the emergency room. We would make that decision at the time of definitive debridement. So other than that, no, I think that could be a first case, assuming you work in a system where you can get it on as a first case.
I would also agree with that. I think sometimes if you don't have the opportunity to have an OR available to you the next day, then it becomes a little trickier to just put it on for me for the next day. And the next day may end up being the next afternoon or the next evening, and you're kind of riding the add-on board, in which case now you're kind of pushing that 24-hour limit, at which point would it have just been worth just doing it in the middle of the night as an emergency? That's something to think about. But if you have the resources to do it, I would say wait till the next day as well.
So, Dr. Ryan, it's the next. So, let's say you go along with the same thing, and at your center, this is on the board for you the next day. What do you tell anesthesiology? I mean, you got to fit this in somewhere. What are you telling them about the level of urgency, or that you tell them the front desk, or how do you kind of label this case with regard to urgency?
I would describe it as urgent, should go within 24 hours of arrival at the center, ideally. And then the one caveat I also have is, I mean, certainly the lack of gross contamination is a huge factor in the urgency for this. But a lot of times those are not the most trained eyes looking for gross contamination. It's hard to evaluate that in the emergency department. But yeah, I would push to have this for first case. And if it wasn't going to get done that next day, I would probably then take it in the middle of the night if I had to work around those contingencies.
Okay, so I had some, kind of other things that might change your timing. So it sounds to me, 24 hours is a lot of what I'm hearing here. So if you didn't have your trauma block until 1 p.m., let's say, it sounds to me like you guys are saying that's probably okay. Did anyone feel like strongly that it has to go first thing in the morning? I didn't really hear that.
No, I don't necessarily think so.
Okay, so in that case, then the other question we can leave to another case. What if what if someone wants to put a suture in the wound? Does anybody allow that? This is something I've been seeing now, and I've complete control to shut it down. And I can't say that I've put a complete moratorium on it, but I've come close to a couple of times. But then, I haven't seen a problem yet.
I'll tell you, where I trained, they routinely closed with a running suture, open wounds in the ED after a betadine washout. And I think that helps kind of limit further contamination. So
Dr.
we
Reid?
could do that.
No, typically haven't done that. I mean, if you wanted to wash it out, who's washing it out? And the question is, is it just shooting some saline at it and closing it up? I'm assuming that it's not under tension too, because you don't want to put sutures in that pulled under tension and create sort of a vascular kind of zone of injury. So typically, no, it's been a matter of just gauze, saline, plus or minus powder.
Yeah, sounds like a possible study because I mean, like I said, it's one of these things. It's almost like back when we started closing open fractures in the operating room on the first trip, right? That initially seemed kind of crazy, and then actually Bill DeLong, I think, paper was the one that kind of said at Cooper, showing that you could actually do that, and now that's kind of what is commonly done. Not saying that we should do it, but it's interesting. I didn't realize. Thought I was the only one seeing it.
But that depends on who's doing that debridement. I mean, obviously, if it's you or your partner or somebody you trust who's doing all that, that's a whole different.
Yeah, I would say
somebody in the ED.
Yeah, it's probably an ortho resident at a training center. So I guess
You would hope, but no offense to any med students in the crowd, it may just be, a third year med student and it may be closed under tension. So that's what makes me afraid about it.
good point. Does anyone have a problem? Does anything change if antibiotics were not given in time? You found out that the patient didn't get antibiotics until late. Dr. Galos, does that change your timing of treatment? Like you say in the morning, like I got to do this guy a little sooner. I may have to bump something to get this guy done because I really don't want to wait too late. He didn't get his antibiotic.
No, I don't think so. I think I would just start the antibiotics once if you found that out, once you find it out that the antibiotics were delayed, start them right away. And then I would just continue on.
Okay, so suboptimal, but
Right.
in this case, maybe not changing things. Okay, we'll kind of get to some of the other cases. So I think I'm going to say some of the, yeah. Oh, sorry, Dr. Apple.
Has the PTSF changed their recommendations that open fractures be the OR for debridement within 6 or 8 hours, like it used to recommend? Anybody?
I believe it's 24 hours.
Yeah, originally it was
watching about that, but I'm
It
pretty
was
sure.
pushed to 8, and then I believe now it doesn't appear as a time anymore. I don't think it's tracked any longer as an item.
I think that certain things have to happen right away, right? So antibiotics certainly easy enough to do. Reduction, sterile dressing, splint, etc. Compartment monitoring, and in a case like this, stable, probably type 2 open tibia fracture, probably can have formal debridement in daylight. And I think it's important also to note waiting is not the same as doing nothing, right? You're doing something. You just may not have to do the definitive treatment right there. So here's another alternative. 28-year-old high energy rollover on a farm property, visible contamination. It's 10:45 p.m. Pretty ugly soft tissue injury, as you can see. I'm not even show the X-ray. You just imagine it's bad. Patient gets antibiotics. Dr. Reid, what are you thinking? There's more of a Penn State case.
I'm not sure what that means exactly.
Well, it's not a Philadelphia case.
Penetrating trauma.
Although I would say an ATV rollover is just not on the farm property, unless you're living out where I live.
Yeah, so the problem, I have is when I was trained. I have a psychological problem that I was trained in the 6-hour rule. And if I went to bed at night with that sitting in the ED, I couldn't sleep. I simply wouldn't be able to sleep. And that's my own, how I was trained. I have these voices in my head that, so I want to be completely clear about that. But I also think that, there's a lot going on there. And I think that would be best, at least with the original debridement. I think it's going to shorten, it's going to rotate, put tension on and things. And I would probably debride it and put an external fixator on it. I wouldn't do anything in the way of definitive coverage, and sort of package it at least before I went to bed. To me, that's a go to the OR middle of the night.
Middle of the night for you. Okay. Quick answers from the rest of the panel. Dr. Galos, A, B, or C?
A.
Ryan?
That's an A for me too.
Dr. Mir?
A.
Okay. All right. So I guess the question is, does 24 hours, within 24 hours apply? Is it the soil manure contamination? Is it the size of the wounds? What is it that drives it more? What if it was just a rollover injury here in North Philadelphia, ATV injury? Is it the wounds? Is it the both things? Dr. Mir? The wound plus the contamination, this type of contamination. What if it wasn't a farm injury?
Yeah. So for me, it's the soil contamination.
Okay.
And here in Tampa, we also get people injured in the water, and the bay is like a giant petri dish. So we also do those more urgently. So yeah, it's the contamination. Just the wound itself, I'd probably wait first thing in the morning, but with that contamination, it's what drives me.
Okay. I don't want to get too much into too much definitive treatment, but I will ask, is when you take this, for most of you guys, is going to be external fixations? Anybody do an unreamed nail for contaminated open fractures that probably need coverage?
Can I give you a cheaper, potentially better alternative?
Yeah.
Yeah, so we do a lot of damage control plating for these wide open type 3 open fractures where you're staring at the tibia. It's just easier to do. It's a lot cheaper, and you're literally staring at the bone. So putting on a little temporary, 3-5 plate and then adding a splint and a wound vac is kind of what we've done, both when I was at Vanderbilt and now in Tampa, and we publish on it as well, and it works well.
Okay, so as a temporizing
Correct.
treatment for a patient with a planned staged return to the operating room.
Absolutely, temporizing, and it'll be removed later when we nail it or do definitive fixation.
Okay, interesting. So I think some of the takeaways from this, what I'm hearing is that it's the contamination here, right? So, and that's something you're going to have to make a decision. It's a little bit of history taking. Obviously, it's some physical examination. It's a combination of things, right? So how contaminated is it? Is this something that you're more worried, regardless of how quickly they get antibiotics, that waiting till the next day is a problem? So I'm kind of hearing from most of the panel, it sounds like you all said this was a sort of go middle of the night type of case. So, yeah, so although the literature weakens the 6-hour rule, it doesn't say everybody should wait. So gross contamination, farmyard, farm, type contaminated injuries, open water, injuries, are not ones you want to go to sleep on, like Dr. Reid said. So your goal is to reduce bioburden, and don't compromise your definitive reconstruction. But that's a now case. All right, great. So let's move into something maybe a little bit different. 10 p.m. open ankle fracture dislocation in a 78-year-old woman. She's got diabetes, neuropathy, BMI is 36, low energy fall. So here you got your sort of typical looking medial laceration, a lot of soft tissue injury, but maybe not grossly contaminated. So is this a case? So it's 10 p.m. Is this a case you're going to go now, or are you going to first thing in the morning, or kind of later in the day? Dr. Ryan, what do you think?
Yeah, for me, this is either first case in the morning or even later in the day if necessary. I think for these elderly, like low energy falls, one, if there's no degree of contamination, that's reassuring. And then sometimes the soft tissue injury is the deep soft tissue injury does not reflect what the skin injury is, because a lot of times it's a skin tear from their torsional injury.
Dr. Galos, thoughts?
Yeah, I would agree. B or C, depending on how the day looks. I wouldn't do this in the middle of the night. For the same
Okay.
reasons.
Dr. Reid?
Yeah, I agree. Antibiotics, get their glucose under control, have the medicine team see them and do them either B or C.
Okay. Dr. Mir?
Yeah, I agree with all that. We're kind of lucky to have 2 trauma rooms every day. So usually we try to prioritize open fractures whenever possible to get them done early.
Okay. Well, I guess let me ask, if you don't have a trauma room, and maybe I'm not speaking to the right group of panelists here, but so let's say you have this case and your trauma room doesn't start till later, and you already have like kind of a big case in there that's been waiting to go. How do you triage this? Maybe I'll go back to Dr. Ryan. Do you ask someone to get bumped? Do you put off your case that you kind of teed up for today, that you kind of put into your trauma block because you need to get it done? How do you navigate that?
So it totally depends for me. If the big case I've been preparing for, I probably would just do it after that case. Like I would feel comfortable doing it later in that day. My thought behind doing that is potentially saving this patient a second surgery. Like I would be able to focus on their injury and treat them potentially definitively, rather than having them sit in the hospital in an external fixator, and potentially contaminating wounds that way, and especially for elderly people.
Okay. There's a little bit of data on this, specifically for open ankle fractures, and this is a multi-center retrospective review that was from a few years ago. I wouldn't say the relative risks were massive, maybe 1.3 or something like that, that there were independent risk factors, including times to wound closure. And again, I want to say it was like maybe in the 1.2, 1.3, but statistically significant increased risk with increased time to wound closure for an ankle fracture. So interesting, it's good to know. And I think some of my takeaways that I'm hearing is that sometimes logistics, I think, can hurt patients. Maybe you have to think about reduction quality. Now, this one, you sort of have the open wound medially, so the medial skin's not going to get any worse. But you may have cases where the longer you leave an ankle fracture dislocation that's open maybe, but the skin is still threatened. If the reduction is not great, I think that can sometimes get worse the longer you wait, or if they kind of shift out of the splint. We're going to talk a little bit about this, I think, at the end of the day too, in our last session. So Anything with, does the host, if the patient is very high risk for infection, does that change your mind at all, Dr. Reed? In terms of
Yeah,
timing?
I worry all the time. I just worry. I mean, I think a smoker, diabetic with an A1C of 10, I would be.
Because if let's say if you're waiting until after Dr. Ryan's got his big case, but now the OR staff is, I mean, if it's our place, now they're telling you like, we gotta go down to 2 rooms or something like that, and not
Yeah.
enough staff.
I think it has to, then at that point, we're gonna have to call an emergency. I think that's the secret, well, what is it? Is it urgent or it's an emergent? If you say it's urgent, you have a certain set of rules. If you say it's, oh no, this is emergent, it has to be there within an hour, all of a sudden it's like, you're really gonna call it that? Yeah, I'm really gonna pull that card and I'm gonna call it an emergency. If it's 2 PM, came in at 10 the night before, and like you're
It looks like it might
staring,
happen.
all of a sudden you're losing your room, you go, yeah, that's an emergency now.
Okay, Dr. Mir, any thoughts on that? Have you had to do that? Where you get late in the day where the open fracture and you're like 24 hours, but now I'm pushing it, and then you have to tell anesthesia, well, now it's an emergency?
I'm hesitant to pull the emergency card on something that you sat on for hours, so I'll still call it urgent, but we have a 5-tier leveling system with different time points. I'd maybe make it like a level 2, which is within 2 hours. But the emergent in our place really can trigger a review. So and again, the questioning of, hey, it sat here all night and now you're calling an emergency. We'd like to call that the neurosurgery emergency, when they wait till all their cases roll back and then call something emergent. We don't like to play like that.
If I may,
Yeah.
I think there's a good case for why closing it in the ED, like a loose closure in the ED, would kind of change some of the factors for me on this patient. Like if this wound was closed, I'm much more comfortable waiting a little bit longer than if it was an open 10-centimeter wound under a splint, as that paper mentioned.
So advocating for the ED closure.
Well, yeah, if you're gonna do that too. Well, I mean, I think also, stabilizing the medial mal can go, like a K-wire up the medial mal. If you're gonna do that, then it brings the whole soft tissue envelope over and probably allows a closure. But again, I'm not sure how much it buys you. I don't know. I just don't know.
I think one other thing to consider for this case is, somebody with diabetic neuropathy and open wound like that is at high risk for infection if you're going to start creating other incisions and everything else. So in my hands, not having seen the x-rays, I'll oftentimes, use a hindfoot nail, especially in the lower functioning individuals. That way the hardware is not, you're not gonna have any screws under the medial mal where that open wound is. You don't have to deal with that skin issue if there is one. But those implants don't necessarily live on our shelves 24/7, so you have to call them in, they have to get processed. So that may ultimately delay taking this patient to the OR if you're going to try to do that as your definitive fixation right off the bat, which is probably what I would do anyway. So,
Okay. Great. All right. Well,
And I would just add one comment
sure.
on if you are going to have an ED closure on this, the post-reduction splinted films better look really good, because otherwise you suddenly now have that wound under tension if it's shifted laterally, if the tail is shifted laterally at all.
Yeah, and I think that skin is so tenuous that you only get one shot at closure. If it fails, you're probably looking at a flat. So I would agree with that comment.
Yeah, you're potentially worse off if you put sutures in and then it subluxes than if you just didn't put any sutures in. So yeah, it is definitely a kind of definitive step that you're taking. It's interesting. Right? We had a case recently that was an open ankle fracture in an older patient who had bad vascular disease to begin with, really bad, and then he had some acute injury on top of it. So I'm in the OR with the vascular surgeon, and he was amazed that I was even going to consider closing the medial open fracture wound. And I was like, we just have these different approaches to how you handle this. In his mind, he was like, he would never ever close like a wound like that in a compromised patient. I'm like, it's like literally open, looking at his fracture going into his joint. I mean, I have to do something, of course I'm going to try to do it under minimal tension. But it's just, I think in orthopedics, we're very eager to just kind of like close everything up, let the bacteria get in. And then, when you see a lot of patients in clinic and follow up and, you've been doing this long enough, you do see the complications sometimes from closures that are under tension. Is that fair to say, panel?
Yeah.
Yep.
Okay. Yeah, it sounds like a study. All right, here's another case. Open knee, proximal tibia injury, pulseless foot. The foot is cool. So I think I know kind of where we're going with this, but again, this is an open fracture, but now you have suggestion of a popliteal injury. So antibiotics get started. So we're veering a little bit off course here. I mean, I guess I'll ask first, does anyone think this is not a now case? I mean, the patient's got a popliteal artery injury. So in terms of the open fracture, would everybody agree they're going to do something when this patient gets taken to the OR? Or
Yes, Your Honor.
or does anyone disagree? Okay, I'll take that as a yes.
Agreed.
So maybe in this case, I can ask the question. So that's just something to keep in mind, right? So I'm presenting this as, here's this patient with an open fracture that has a pulseless foot. I mean, obviously, if you're on the front lines, it's your job to make sure that you recognize that there is a vascular injury, right? So here's an open fracture. You're thinking about all the timing stuff we just talked about, but make sure you're getting ABIs, make sure you're checking pulses, make sure you're recognizing that this is an injury that could also have a vascular component to it. And hopefully, something like that is picked up quickly. And let's just say hard vascular injury signs like this, that it is something that's probably going to need to be dealt with urgently and then or immediately. And then on top of it, there's also an open fracture. So maybe I'll ask then Dr. Galos, who's how are you coordinating that with vascular surgery? Like what are the priorities? Patient got antibiotics. So what else is the priority sequence? How do you sort of help to orchestrate that from the ortho standpoint?
So, I mean, I think the way that we've all been kind of taught is that this is obviously a joint effort between us and the vascular surgeons. The priority obviously is to restore flow to the foot and to restore flow through the popliteal artery. But we are, I think, as orthopedic surgeons, critical in helping to facilitate that for the vascular surgeons. And so, I think traditional dogma has always been orthopedics goes first, X fixes, vascular does the vascular repair. And that's kind of what we have always been taught. That's not necessarily how it always happens in practice. Oftentimes, this will go into a trauma room. The vascular surgeons are already there. We're being called in. And so we're on our way in, and the vascular surgeons are already getting started. And so now you're like, okay, well, you guys are already doing something. We should probably X fix this before you guys do a definitive repair, because we're going to have to reduce the fracture, potentially put your repair on some tension as we're reducing it, and could compromise what you've just done and have you redo it. And usually, sometimes that doesn't necessarily convince them to let us go first. They just want to finish and get their part done, and then we'll put the X fix on. And after having a discussion with them, we added some redundancy to our repair so that when you guys are pull out the length, it'll be okay. Sometimes that works and sometimes it doesn't, in which case they may have to come back and redo what they had done, which is obviously not ideal. So it is a constant kind of back and forth. I think a discussion with them early on as to what needs to happen is important. I think a lot of times their hesitation with us going first comes to the positioning of the leg. Typically, we put this in some sort of slight flexion. They want the leg typically in a little bit more flexion to be able to get behind the leg, behind the knee a little bit easier. Even if we talk about adjusting the X fix for them to allow for that to happen, it's still the X fix is in the way now. So it becomes a logistical challenge sometimes from their side of things, and then becomes a logistical challenge on our side of things too. So, but I think it's a kind of a constant back and forth with them as to how best to address this, and having them understand what our goals are in terms of restoring length, alignment, and rotation with the X fix, to allow for their repair to either happen after we do that, or allow for their repair to withstand us doing that.
Dr. Ryan, how about at your center? How do you see these managed, and how do you manage them, or would like to have them managed better, I guess?
It's a very similar experience in which obviously the like textbook answer of providing bony stabilization prior to them doing their definitive bypass is not often what happens, because that they for them it's easier that they're able to flex the knee up to be able to do their portion of the procedure, which also then leaves us in a predicament, because they can potentially limit us re-achieving length. And I think so it is definitely a conversation that I've had in terms of getting them to understand that they could just externally rotate the leg and put on the external fixator. But it's a constant battle, and it's pretty surgeon dependent, depending on whether your vascular surgeon's used to dealing with acute traumatic injuries like this.
Dr. Mir, how do you guys do it in Tampa?
Yeah, so when I first got here 11 years ago, it was a little bit of what you guys are describing. And so I actually did a lit review and then presented grand rounds of vascular to convince them. And we came up with a multidisciplinary protocol that then people had to answer to. So we actually do have that protocol in place. And then there was a big multi-center study. I think Tornado led it, and we were part of it. A lot of centers were part of it, that showed that if they go first, you're more likely to have a failure. So, and that was after I'd already convinced him, so that just cemented it. So the big thing with that policy, though, is that we made it clear that we will own all the issues with the leg. We'll do the debridement of the open fracture. We'll do the bony stabilization. We'll do the fasciotomies. We'll come back after they're done with their vascular repair to then put on wound vacs, splints, etc. So it's not like we're doing our part and just, yeah, see you guys, we're out. We'll actually come back at the end and do what needs to be done. The one caveat, though, is the ischemic time. If the ischemic time is approaching 6 hours, then we actually will let them put in a temporary shunt to start with, and then do our thing, ideally in under an hour, and then have them come back and do their definitive repair. But we've kind of, now that there was one holdout, but he's no longer taking call. He was the last one who would still build in the extra length to the graft, and then it would go down later. We've kind of, that whole regime is now gone. So we do temporary shunts for long ischemic time, and then definitive repair only after we've reestablished skeletal stability.
Interesting. The paper you're referring to, there were so many different permutations, I think, of pathways, if I recall correctly, like 6 or more in terms of who goes first, what they do first, and all the different centers. So a lot of different potential ways to approach it. I'm going to say maybe the takeaway from this is that you got to communicate with vascular surgery early and often, and hopefully they recognize the importance of skeletal stability for their sake and for the patient's sake. And that I think you need to make sure on our end you're ready to go, you have what you need. A lot of times this patient will go into a room where they're not, it's put in as a vascular case, maybe like Dr. Galos said, maybe they've already taken the patient to the operating room. So I think for orthopedics, it's communicating with the vascular team frequently. It's making sure you have what you need. So again, if I go in that room, they're set up for vascular, I have to make sure they have what we need, that we have our instruments there, we have a drill, that kind of stuff that they may not have pulled. We're able to take imaging, etc. And that you have to be able to do what you need to very efficiently. That's the other thing. So, the vascular team needs to feel confident that you can work efficiently. Like if they're going to let you do something while there's ischemic time on the clock, that you can do what you need to do very quickly and efficiently.
I would like to second that. I think, these cases when there's a lot of things going on, time is really of the essence. This is not a case where you're taking like a second-year resident through how to put an X-Fix on. This is something you do quickly. This should be a 20-minute case at most, real quick, get it in, get out of the way. and let the vascular team do their part, and then help out like Dr. Mir was saying with anything that needs to happen after the fact. But the idea is you don't want to be the cog in the wheel. You want to help kind of move things along.
Yeah, you don't want the vascular team to be responsible for the fasciotomies that historically have not gone well. And the other point that Hassan made was that having a protocol that you've all agreed upon ahead of time and had the conversation in the cold light of day, they understand orthopedic problems, we understand the vascular problems. It just makes the whole thing, you're not reinventing the wheel every time a case comes in. The problem with this is, these happen even at a mostly trauma center, not that frequently. So that's the problem. You don't get to iterate that too often. So, new people come on staff, they haven't seen the protocol.
Right. Yeah, know exactly what you mean. Good. All right. So I think pointless or needless to say, this vascular limb is not a wait till the morning open fracture, right? So this case is going to the OR right away, and you need to, fit in and do your job efficiently, take care of that patient. Okay. Slightly different case. 1 a.m. ballistic fracture, gunshot wound. Patient comes in, they have a tibia shaft fracture. You see small entrance and exit wounds. Patient does not have a vascular injury. It's not intra-articular. I'm sorry, I don't have an X-ray. It's just a mid-shaft fracture. Actually, there is an X-ray in the background. You can see. But mid-shaft tibia fracture, small bullet wounds. So patient gets, NSF in the emergency department. It's 1 a.m. Dr. Reid, what is this for timing purposes? Are you handling this any differently than you were maybe with our other tibia fracture, with the laceration and the motorcycle crash?
I've never seen this injury. I don't know what you're talking about. There's been an iteration to this whole thing over the course of time. I think it initially we were much more aggressive when I was a fellow, and then we went through this period where we treated them with cefazolin and we nailed them either simultaneously or the next day. Sometimes they were out of the hospital within 24 hours or less. And now I see it coming back that maybe we're being a little too cavalier about these. And like, is the bullet sitting under the skin on the far side? But this looks like no compartment issues, no flow issues, no nerve issues. And it's truly a low velocity 9mm. I would probably make this a next morning case.
Okay. Next morning, Dr. Mir, when would you do this case?
Yeah, next morning or sometime through the day, as was mentioned. I guess the worry on these is the medial soft tissues, right? So that may dictate whether I'm doing it first thing versus later in the day, but certainly not in the middle of the night.
Okay. Dr. Ryan?
I agree with everything that's been said. First thing or later that day.
Okay. Well, maybe I'll shift Dr. Galos then. So when does an open fracture from a gunshot injury need a formal debridement in the operating room? So, you get a call from the resident, this patient came in with a GSW, they have a gunshot injury, and they have a fracture, tibia fracture, whatever fracture. So in general, what things are you thinking, or you want to make sure the resident is thinking, whoever's calling you, and that you have to decide to do a formal IND versus that maybe you don't?
I think in general, if you have like a sub-centimeter wound, I think those typically we don't need to do a formal debridement on. That being said, I think it's very location dependent as well. I think, you get shot in the femur, you have a large soft tissue envelope, small wound. There's not a huge concern there if you have a sub-centimeter wound. If you have a larger wound, then that would probably make me more likely to want to wash it out. But to me, the biggest concern, like Dr. Mir had mentioned, is that kind of anteromedial, medial-sided tibia, where there's really very little soft tissue coverage. Even a small sub-centimeter wound sometimes can be a concern. Oftentimes, you can have little pieces of bone sticking out from that, just from the comminution related to the ballistics injury. And so those tend to be kind of the ones I'm concerned about. Won't necessarily make me take it in the middle of the night, but I may be more likely to open that area up, debride it, and then close it in a more formal fashion than just kind of letting the gunshot wound kind of drain out like we had, traditionally had been doing for a while.
Okay, Dr. Reed, what if it's not a sub-centimeter wound, a little bigger, 3 centimeter wound or something that looks worse than that? No exposed bone, but just big wound.
Yeah, I always would err on the side of debriding that. I think, that just, they just sit back and look at it and you go, is that going to do okay or not do okay? And I would like to, again, go to bed knowing it was debrided.
If it's a much bigger wound, it's also less likely that it was a low velocity,
Yeah.
low energy type of, small caliber handgun injury, and maybe something like a rifle injury or something where perhaps there's more soft tissue injury that's going to devitalize and be a nidus for infection, I guess, right?
I mean, we talk about, the whole ballistics thing, the next question is a high energy rifle injury, which is a velocity component, versus the mass component of the kinetic energy equation, a 45 to the tibia, the dirty hairy gun is a little different than a 9mm. So.
Okay. So I think some of the takeaways, because we certainly see these here, and I'm sure maybe a lot of learners in the audience are going to come across patients with, ballistic gunshot injuries. So I think fracture timing depends probably on energy, right? So is it a high energy rifle injury? Is it, highly contaminated? And if there's metal fragments in there, there's some contamination by definition. Where it is, if it's in the joint, right? So that oftentimes, if you have a bullet in the joint, you're going to the operating room. So distal femur gunshot injury, bullet still in the joint. And then instability in terms of whether you'll have to fix that fracture. So I think that we don't have great data on this, but we have some data, and certainly we've tried to do our part to contribute to that since we see so much volume here. That if you have low velocity civilian ballistic injuries without gross contamination or obvious joint or bowel involvement, a lot of those cases may not need emergent debridement, although they are open injuries. How you classify them is a little bit controversial. But gunshot injuries are not all the same, right? So if it seems like, and we're not forensic pathologists, you're not going to try to, exactly diagnose what type of bullet that was, but you need to look at the big clinical picture. Does it look like a high energy wound? Does it look like a shotgun injury? Hopefully you can distinguish that. And then try to piece together, is it something that's bowel contaminated for sure, right? Did a bullet go, through the bowel into the femoral neck or something like that, right? And then, of course, if something's intra-articular and still sitting there, it probably needs to come out. So I think those, are my takeaways for ballistic fracture, surgery timing.
So Saqib, let me flip it back to you for a second. So, you see a lot of ballistic injuries to the lower extremity, right? And so by definition, there is some contamination. I mean, there is some bacteria being brought into the body from that, right? And so how often do you factor in the competency of the host, A host, B host, do you think, well, this is not a very immunocompetent host. Do I treat this differently than I would a 22-year-old healthy person? I mean, do you go?
That's a good question. No, I probably don't. Maybe I should. So if the patient, I guess I'm looking more at the. I'm probably focused more on the wound location. Is there is it a subcutaneous area that there's bone exposed? I guess I focus more on that when I'm thinking about, does this need a formal debridement than the host? But you're right, maybe that should drive the decision making a little bit too. But it's not something I've really kind of strongly considered. But it's food for thought. Dr. Galos?
Do any of you guys routinely Even a sub-centimeter wound, just ellipse out the wound to get a nice closure. That's something you guys do routinely.
I definitely do that, especially for tibia wounds where there's not a lot of soft tissue coverage. I think it's very similar to like leaving external fixator pin sites open, like just having a track from the outside world to the bone that you have hardware on.
As long as you can get it without too much tension. So sometimes an ellipse becomes like, you're taking out this massive chunk in an area where you don't have a lot of excursion of the tissue. So yeah. Okay. All right, last few minutes of the session. So 2 a.m. low energy distal femur fracture in a frail patient. So obviously you can see it's a periprosthetic fracture, 82-year-old woman, nursing facility. She's anticoagulated, she's anemic, she's medically fragile. So I'm not even going to give you the middle of the night option here. So it's really, the question is this a case that you're going to try to get to first thing in the morning, or are you going to wait until this patient's a little bit more optimized? And I don't know how much you can get her unanticoagulated, but she's definitely open, she's oozing. You can imagine the mechanism, the shaft probably poked through. So this is not an abrasion, and it's a femur fracture on top of it. So Dr. Mir, what's your thought process? How much are you trying to like optimize this patient? Your medical team is, not able to see this patient until later. How much are you pushing and trying to get this case done from a time standpoint?
Yeah, I'm not worried about from an open fracture standpoint that this is urgent at all. From a femoral shaft standpoint, that pushes me to want to get this done within 24 hours. I think that ideally you want to at least be going towards correcting her anemia, correcting whatever medical issues are able to be optimized prior to surgery, because you're nailing a long bone, you're going to have some intraoperative blood loss, whether you see it or not. And so, yeah, this is not a first thing in the morning unless she's been optimized overnight. If she's been optimized, great, we'll go. But otherwise, I'm not pushing to get this to go first thing.
Dr. Ryan, how do you guys do it at your center?
Yeah, I totally agree with that. Like it's definitely a life over limb situation for this patient who's medically fragile. Certainly operating through anticoagulation, that's something we routinely do for hip fractures. I would extend that to this as long as it's within reason, and not.
So patients on Xarelto took it, last night.
Yeah, that would be a non-factor for me personally, but
Because it's an open fracture or because it's a femur that you think?
Really for both reasons. And then the more concerning thing for me would be the anemia and how significant that was, and correcting that.
Okay, Dr. Galos, Dr. Reid.
I would agree with all that said. I think optimizing her medically is going to be important, obviously, because she is so medically frail. And like Dr. Ryan was saying, life over limb. But yeah, I think get her teed up and hopefully do it the next day at some point.
Yeah, nothing to add.
Okay. So I think interesting. I think that seems like everybody wants to get this done. There's a couple of things pushing you, right? Another thing important, this is a tiny poke hole wound. So it's just, for a lot of learners in the audience, if you have a tiny wound that's bleeding and bleeding and bleeding and kind of doesn't stop as quickly as it should, right? This could be an open fracture, right? So if there's a fracture there, you have a tiny wound, but it doesn't stop oozing, it's probably all that fracture hematoma that is not allowing, a normal shallow soft tissue wound to heal. And instead it's just decompressing hematoma and just oozing, right? So, and that open wound doesn't have to be directly over the fracture, right? You have to just imagine how it could have sort of telescoped or projected. Sometimes you may see gas on imaging, especially on CT, easy to see gas. So that should give you suspicion if you see gas in the fracture site on a CT. So make sure you examine everything. Sometimes with pelvic injuries, you could have open fractures through perineal, vaginal, rectal tears that would be open as well. It's not just the skin. All right.
Well, that point you make that was really important, like, the missed open fracture is a big deal. That you're told that it's closed in the ED, and a couple of days go by and you take it to the OR and you unwrap this thing for the first time and you're like, oh shit.
Yeah, and it's a
It's an
distal
open
humerus, you might do a
fracture.
big case now, yeah.
Yeah, right.
That could
Oof, that'll ruin your day.
Yeah, so don't miss the open fracture. All right, for the sake of time, I'll skip through this. This is the not so small, gunshot injury, right? I left that picture here, and you can see exactly what he was shot with, unfortunately. So sort of opposite end of the spectrum. So just to wrap up, I'll say, things to keep in mind: antibiotics, tetanus. If you have gross contamination, make sure you recognize that. Splint reduction. Make sure the skin is no longer threatened or tented. Make sure you document your neurovascular exam. We didn't talk about that so much. Make sure there's a clear handoff. And then if you're coordinating with other services like vascular, make sure you communicate very clearly with them. Other things are system issues, right? Sometimes you may be at a place where there's a dedicated trauma block, and you have to start thinking about if you don't have it till the afternoon, if it's a first thing in the morning case, are you bumping somebody? We didn't really get into this, but let's say, if you want to do it first thing in the morning, it requires bumping someone. Well, which is the case that you would potentially want to, bump somebody for? So I think that's going to be different at center. We all say we're going to do the first case, but what if you don't have that morning first case flexibility? Make sure you have standardized order sets at your centers for open fractures. This is a big thing, and it's not that hard to do. And I think, again, if you're at an accredited trauma center, there's a lot of push to do it anyway. Just kind of wrap up here. I kind of said that the early antibiotics foundations, we say within 1 hour. Maybe there's some evidence even to suggest that literature might be mixed. We know that the universal 6-hour IND rule is not super strongly supported. And generally speaking, a lot of open fractures you can take to the OR within 24 hours with the appropriate team. But if you have a dysvascular limb, compartment syndrome, we had that farm injury with gross contamination. If you have a really mangled extremity, like we saw some examples, then you may need to go to the OR. We didn't really talk about if you have physiologic instability, the damage control case, that may be a now case as well. And the quality of the debridement by a team that knows what they're doing, appropriate soft tissue management may matter more than going, immediately and looking at midnight. So I don't know if we have time for this necessarily, but maybe I'll just ask one question of the panel. Dr. Mir, what's one open fracture you would absolutely take after midnight? Quick.
Yeah, grossly open contaminated wound, whether land or sea.
Okay. Dr. Ryan, what about for you?
Yeah, I agree with that. And then I add any dysvascular emergency.
Dr. Galos, what's like one open fracture you're definitely comfortable taking first case tomorrow?
The gunshot wound, the sub-centimeter gunshot wound to the tibia.
Okay. And Dr. Reid, what's the one most important thing you want to make sure all these patients get done in the ED?
Antibiotics.
Antibiotics. Okay, great.
Even pre-ED, if you can manage that in your system.
Okay. So this is just a summary slide. All these videos are going to get recorded. They'll all go up on the OrthoClips YouTube channel at some point. So you'll see all of this. I'm not going to read through everything, but this is kind of, I think, somewhat of a summary of what we talked about. So give antibiotics now. 6-hour rule is not necessarily a rule. I think we talked about contamination, safe delay, but doesn't mean you're not doing anything. And sometimes the best midnight decision may be to resuscitate, reduce, splint, monitor, operate with the right team at first light. So thank you very much. Thanks to our panel. And we'll move on to the next section.
Quick comment.
Yes.
So the only thing supporting a 6-hour rule is that's the time period where bacteria that are free flowing will form biofilm. That's about how long that takes. And at that point, it's hard to irrigate it away. You have to sort of sharply debride it. So that's the 6-hour rule is linked to the time it takes bacteria to make biofilm.
Good point. Yes, thanks for bringing that up. Great. Thank you. All right, into the next session.